Welcome, everyone. I'm Pamela Schaff. I'm the director of the HEAL and Narrative Medicine programs, and it's my pleasure to welcome you to today's capstone presentations by our Narrative Medicine Master's students. The work you see today represents our students' summative experience in the program. Each student has examined a topic inspired by the principles of narrative medicine and that draws on many elements of their coursework and learning throughout the program. I want to acknowledge the commitment of our narrative medicine faculty who have served as advisors and mentors for our students. Erica Wright, Kairos Lobrera, Ronan Hallowell, Lynn Boyd Judson, Emily Ziemer, Abby Resminsky, and Jonathan Chow. Thank you for all of your guidance. I also want to thank Jimena Patino Perez and Paige Tonks for all of their support of our students and of today's event. For those of you who may not be familiar with the field of narrative medicine, I just wanted to say a few words about our field. Narrative medicine is a clinical practice, a method, and an interdisciplinary field of study that centers individual and community stories in the service of health and social justice. Dr. Rita Sharon, originator of the field, says, along with their scientific expertise, doctors need the expertise to listen to their patients, to understand as best they can the ordeals of illness, to honor the meanings of their patients' narratives of illness, and to be moved by what they behold so that they can act on their patients' behalf. Narrative medicine is clinical practice fortified by narrative competence, the capacity to recognize, absorb, metabolize, interpret, and be moved by the stories of illness. Simply, she says, it's medicine practiced by someone who knows what to do with stories. Narrative medicine works in a range of settings as a tool for building community, developing a practice of self-reflection, and becoming open to other points of view. Today, our students will share the diverse ways in which they have used narrative medicine's principles and methods to make a difference in the lives of patients, clinicians, and caregivers. We're going to have two groups of presentations, and each one will be followed by a time for question and discussion. So with that, we will get started. And Anya, I turn things over to you.
Awesome, thank you. So my name is Anya Shaw, and my project explores ballet and narrative medicine, a bidirectional practice of storytelling and healing. So those facing serious illness may often struggle to articulate their pain through words. And sometimes when words fall short, what do we turn to? Well, narrative medicine offers us tools such as reflective writing, close listening, close reading. But what if words are simply not enough? So my project explored movement, specifically ballet. And by incorporating ballet into narrative medicine, we reimagined the body not only as a site of suffering, but also as a vesicle for meaning making and for storytelling. So some of the questions we ask ourselves is, how can dance serve as a narrative medicine technique for those whose illness stories resist verbal articulation? What is the impact of visual deprivation on movement, and how does it affect self-awareness? And how does dance promote narrative cohesive and community building? So to conduct my project, I partnered with Anna Wasman-Cox, who works at Onco Ballet, and we conducted two 90-minute workshops of all ballet, but it includes different aspects of ballet, such as bar, improvisation, mirroring workshops, and choreography as well. And throughout each of the movements, we explored it with both eyes open and eyes closed to see how that affected our narrative experience. In terms of the survey results, there were about 8 to 10 participants in each workshop, caregivers, patients, and those just in the cancer space in general. They reported that the workshop helped them become more aware of their body and their surroundings. They believed that movement could be used as a narrative medicine tool. And most importantly, they all reported that they would want to do something like this again. So some of the highlights of phrases people have told me and feedback I received was that I felt off balance at first, but then I learned not only to trust myself, but to trust others as well. And that's part of dancing. You're not always just dancing by yourself. You have to trust others. And when you close your eyes and dance, it's even scarier, and you have to rely on the energy of other people when you're doing it as well. Some people reported that removing sight made them more aware, not just of their body, but of what they were feeling as well. And so this project also follows the core tenets of narrative medicine: attention, attention to the body, attention to the self, representation, and affiliation. Affiliation is that community aspect, not only dancing by yourself, but dancing with other people, having to close your eyes and still learn how to dance with others around you, whether that's feeling their energy, holding their hands, moving at the same time and space as them as well. And so overall, this project challenges the idea that stories must begin with words, showing instead that meaning can emerge first from the body and then through language. So honoring the body's narrative role expands narrative medicine to include silence, fragmentation, and nonlinear healing. That is it for my project. I'm going to go ahead and pass it off to Caroline now.
All right. Hello, everyone. My name is Caroline Matias, and my capstone is entitled Cultivating Narrative Humility to Improve Patient-Physician Interactions. And I was really inspired by author and physician and founding member of narrative medicine, Dr. Sayantani Dasgupta, who wrote an article entitled Narrative Humility. And the whole essence of narrative humility was a evolution from the idea of cultural humility, or being able to empathize with individuals of other cultures within a clinical interaction, and that itself being a vast restructuring of the idea of cultural competence. So narrative humility here acknowledges that our patient stories are not objects that we can comprehend or master, but rather dynamic entities we can approach and engage with while being open to their ambiguity and contradiction. That's what Dasgupta, one of the quotes from that article. And the whole essence of narrative humility is to be able to tolerate ambiguity in the clinical encounter and not seeking to sort of master or jump to conclusions about a patient's narrative, but rather being open, especially if they do come from a different perspective or different background, to be able to be open and receptive to their narratives, especially through slowing down and active listening and just sort of being very present and engaged within the clinical encounter. So I was inspired by that article, and so my objectives within this capstone were to examine a first-person physician narrative in order to understand how narrative humility is being carried out within the clinical encounter, and then to develop a lesson plan at the end of that that incorporates the ideas of narrative humility into preclinical medical studies. So for that text that I chose The Man Who Mistook His Wife for a Hat by author and physician Dr. Oliver Sacks. And that text is just a series of different stories of true physician encounters that Dr. Sacks had with his patients, and sort of dealing with, as a neurologist, how to deal with patients that sort of see the world differently to him. And although he doesn't use the term narrative humility explicitly within the text, he engages with the core concepts of it several times. So I used the first chapter, which is the same title as the text itself, and I close read the entire chapter. But this is just sort of a short paragraph that is an excerpt of what I close read. And essentially in close reading, I wanted to slow down and pay attention to little nuances. What's the tone? What are certain words that he uses, the word choice that might be different from something else? Or when does he engage with the core concepts of narrative humility in being able to tolerate ambiguity and take in a patient's story very slowly and very engaged? So one sentence that stuck out to me was, "He faced me as he spoke, was oriented towards me, and yet there was something the matter. It was difficult to formulate. He faced me with his ears being italicized, I came to think, but not with his eyes." And so this was a sentence in him dealing with a patient with visual agnosia. And in close reading it, and again, this is just one piece of a larger chapter that I close read in total, but for example, the idea of ears being italicized. So the idea that Dr. Sacks, when engaging with this patient, was so attuned to how his patient was and how he was oriented, and the fact that he wasn't facing him with how a patient would traditionally do with his doctor, with his face or with his body, but rather with his ears, and him noticing these small nuances and details that make this patient sort of deviate from the norm, and being able to adjust his care plan in order to take into account just the personhood and the totality of that patient and how different they are from perhaps another traditional encounter. So in close reading this, it sort of teased out to me little pieces of how Dr. Sacks is engaging with narrative humility and seeing the patient and meeting them for who they are, rather than jumping to conclusions and sort of assuming things about this patient's narrative or case, rather than, just sort of slowing down and taking it in. And so I decided to propose a lesson plan for preclinical, particularly MS1 students, in engaging with the concepts of narrative humility. So the theme is what narrative humility looks like in the clinical encounter. And essentially my plan is to give these participants first a printed copy of that essay by Dr. Dasgupta so they can get an idea of what the tenets of narrative humility are as a foundation, and then also a printed copy of that chapter excerpt by Dr. Sachs for them to read before the workshop. And then in keeping with the sort of tradition of narrative medicine workshops, they would come into this space and it would be a small group of students in order to sort of engage more intimate discussion and a better reading and a better discussion of core concepts. And we would go into a writing prompt after they would refamiliarize themselves with the texts. And my writing prompt is very vague and ambiguous on purpose. It's write about a time in which you were unsure, so that the participants can have an idea of remembering a time in which they needed to slow down or tolerate that ambiguity. Maybe they talk about it in clinical encounter, maybe they don't, but just an idea of when they needed to understand that maybe they won't know the full scope of someone's narrative. And then we would go into a discussion particularly about Dr. Sachs' text and the chapter excerpt, and going into a discussion of how he engages with narrative humility and how maybe them, when they go into residency or into their clinical practice, how they're engaging with those core tenets. And so the goal is to allow them to define narrative humility and see how it may improve patient-physician interactions within the clinical encounter so that they can take that on through their work and life studies. So yeah, thank you.
All right, thank you everyone. My name is Sabania. I'm also a student here in the narrative medicine program. So my project is the impact of narrative medicine workshops at the La Linterna Clinic at CHLA. I know Anya explained this a bit, but the signature method in which narrative medicine is practiced or implemented is the narrative medicine workshops. So like she spoke about, the three movements of narrative medicine, attention, representation, affiliation, are most easily practiced through the narrative medicine workshops. So working with La Linterna, we came up with a series for two narrative medicine workshops. And so this will be an exploratory humanistic inquiry into the potential for narrative medicine workshops to support current providers at La Linterna Clinic, which is a trauma-informed space working with immigrants here in Los Angeles, most of whom are undocumented. And so the people that we will be working with for the narrative medicine workshops are physicians, mostly in primary care, psychologists, social workers, lawyers, and other people who are part of the administrative staff at La Linterna. So again, in working with La Linterna, we spoke about what their current needs are, what they're doing for the populations that they're serving. And so working with their team, they said that the most important thing to tackle that the narrative medicine workshops can be fine-tuned to help with are provider-related distress, and that includes things like burnout, stress, and compassion fatigue, as well as feelings of being disconnected from their other providers and their patients. And then again, the research population for these workshops is current staff members at the Children's Hospital Los Angeles La Linterna Clinic. And so in terms of just explaining a little bit about what are the concerns of the current team and why narrative medicine is like the perfect or one of the really good methods in which we can work with the team to help them, I talked a bit about compassion fatigue. And so this is when you have vicarious trauma or secondary trauma and it's coupled with burnout. So just to kind of explain that, secondary trauma, especially for trauma-informed providers, is when you are taking in the stories and receiving the stories of your patients, and it leads to you, because you're having empathetic responses, kind of taking it on, and it can affect you in your work as well. And then burnout's related to mostly workplace kind of stressors and the workload in terms of how many patients and how often you have to work with them. So in terms of narrative medicine as a tool, there have been a lot of past workshops that have been used as a protective factor and with other providers who've worked in similar spaces. So there's a lot of research in terms of emergency department clinicians who've had success with narrative medicine workshops in terms of helping with their stress reduction, as well as other factors like I mentioned, like burnout. And it's also been used in primary care physicians as well as medical residents. So there's been a lot of background and history in terms of how narrative medicine workshops can really help providers, especially when they're working in these high stress environments and with patients who are coming with their own really complicated cases. And then in terms of why La Linterna is a great partner for us here for narrative medicine, like I mentioned, the majority of their clients are immigrants, and of those, mostly they are undocumented. And this serves as an accessible hub right here in Los Angeles and Boyle Heights, in which all of the family's needs are met. So when families come to La Linterna, it's not just their primary care that's being met, but it's also their legal, medical, social needs. And so it already kind of works to have a holistic model towards healthcare. And the clinic already really emphasizes reciprocity, community building, and flattening hierarchies. They have a lot of events with community members, and they want their patients and clients to feel like a part of the community, even as, of course, they're coming to get their needs met. So they're an ideal partner because they already have a lot of the goals that narrative medicine providers and scholars and researchers really believe in, which is, again, flattening hierarchies and having this holistic approach to medicine. So in terms of my research questions, I have them here in yellow. So the main one is, what is the impact of narrative medicine workshops for providers who care for immigrants? So the first one that I wanted to kind of look at more closely is, what are the most pressing emotional and psychosocial issues at play for Los Angeles-based providers of immigrants when working with their patients or clients? So again, what are the things, like we've already talked about, compassion fatigue, they're things that have already been discussed, but what can we kind of target with narrative medicine workshops? The second thing that I will be looking at is, what are the current gaps or areas of growth in providers' coping mechanisms when dealing with these issues? So of course, especially when you are trauma-informed, and again, they have their own training in which they're also become really knowledgeable about the push and pull factors that affect immigration. So they're aware of a lot of the complicated, pressing issues as it relates to immigration, and they have their own coping mechanisms. They're already given a lot of support, but of course, there are ways that we can continue to supplement the coping mechanisms that they already have. And then the last thing I'll be looking at is, do narrative medicine workshops offer a sense of community and opportunities to experience expression, reflection, and emotional regulation? And these are things that I decided to look at based on prior research, as well as my own background a little bit with working with workshops. So in terms of methods, again, this is kind of a pilot intervention, and it's proposed because we are actually currently in the middle of data collection. So these are my kind of methods that I'm doing right now, but we'll be having around 10 participants. So again, all staff members at La Linterna, and they'll be participating in 1 to 2 online narrative medicine workshops. So they have the choice in terms of what works with their schedule, if they want to attend both or just one. So again, like I mentioned, narrative medicine workshops are the primary way in which narrative medicine can be carried out, and those 3 movements can be expressed. So within the workshop, just to kind of give a brief overview, participants will be close reading a poem, they'll be writing to a prompt, and they'll be close reading and sharing their responses as well. So there are many opportunities to kind of get at the attention, representation, and affiliation aspects of narrative medicine. And then also I'll be having follow-up interviews after people participate in the workshops. And again, it will be in terms of who's able to participate. And they will be one-on-one and semi-structured, asking about their experience and trying to kind of tackle these questions in terms of if they did offer a sense of community and they were able to experience expression, reflection, and emotional regulation because of the workshops. And then I will be going through all of the interviews and using software as well as line-by-line manual coding to kind of look to see what are the main benefits that participants express because of their participation in the workshops. And then also I'll be having questionnaires. So of course there will be an intake survey, just getting a little bit of information in terms of who are the people who are participating, whether they're working more on the legal side, which is a very different experience when you're doing providing the legal work for an undocumented immigrant versus a primary care physician, in terms of also their current coping mechanisms as well as their experience in the field, whether they've been working in trauma-informed care for decades or they're kind of new to it. And then again, there will be a post-workshop evaluation, which is in terms of addressing these questions, but also whether they want to participate again, how much the workshops helped with addressing compassion fatigue, building community, and again, providing opportunities for expression, reflection, and emotional regulation. So I kind of just have the schematic here. They'll be taking the survey, they'll participate in 1 to 2 workshops, they'll have their evaluations, and they'll have the interview after. So in terms of expected results, because again, we're in the middle of collecting data, which is super exciting, but it is a pilot intervention, so it's expected that these workshops will hopefully support the provider's current coping mechanisms or offer new ones. And in terms of future studies, we're really excited to see if this could lead to some changes and if we can continue to partner with La Linterna. So I'm hoping, hopefully, if this goes well, we can do in-person workshops and offer a longer series, so more than just 2 workshops here in our community. Yeah, thank you so much.
Thank you. So thank you so much to our first 3 presenters. Be happy to entertain questions from anyone about any of these posters.
Patient-physician relationship. As a physician, I just need to ask, in this kind of shortage we have, and we have only 15 minutes sometimes to speak with patients, how can we encourage a patient-physician, like in this short period of time of doctors like now is overwhelmed with patients? That's a tough one.
That's one of my favorite questions.
Yeah, that also was something that was on my mind in developing this, because obviously this is like ideal in order to, you know, incorporate this. There's a lot of bureaucratic issues to be able to navigate, and a lot of constraints, especially if you work in like a large institution like a hospital or like a university hospital like this. Like, it's hard to be able to break out of that. And so the best sort of approach in being able to improve upon patient-physician relations in being able to like engage with them more closely is just sort of using that allotted time to be able to slow down and being able to sort of incorporate that within that like 20-minute barrier or 15-minute barrier to just, I guess, hold off for the first few moments was what I was thinking, and discussing this with a few physicians that I sort of like bounce this idea off of, like not going straight to chart or not going straight to sort of ask about their diagnosis and care plan, but rather first asking them like how they are, like maybe bringing in something what you talked about like in the last visit, or like their family or something, to sort of engage with them to begin with. And then within those short 15 minutes, and I know it's very difficult probably to like just paying attention to like their body language or their behaviors, or if they're feeling nervous, and taking, even in those small moments, even if you only get a minute to just be able to reassure them within that clinical encounter. And so, yeah, it definitely is something very difficult and something on a larger scale to like work on, being able to have more time with the patient, but starting off within that allotted time, being able to like engage better.
Yeah, my experience has been that slowing down in this way and paying that kind of close attention actually saves time or makes time feel longer or more rich, I guess. I feel that so often we are sort of primed to try to get as much information as we can within this short time, and if we just stop and listen, patients end up telling us a whole lot more. And if we're looking and listening with all of our senses, I think we can get yeah. So, other questions? Yeah.
I have a question for Saba. Okay. Have you done a workshop yet?
No, we're doing it on Friday. Well, there have been, unfortunately, not to get into like the nitty gritty, but with a lot of the new changes, they actually have had to downsize and they were not able to meet as often. So we're kind of having the workshops take place when they all have a break as a group, they come together. So there had to be a bit of rescheduling just to kind of make sure that they could all come. But yeah, we're having one on Friday, but we're really excited to see how it goes.
I wanted to ask what before.
Oh, initially.
Initial.
Yeah.
All good. Good luck on the
Thank
workshop.
you.
I had a question, Anya, for you. Oh, Marche, did you want to ask? Okay. I'll ask one, then I'll let you. I wanted to ask you, and I know you had just a short time to speak, but I was really impressed with the way that you close read the dance. And if you could just speak a little bit about what that looked like, because you use such lovely words in describing that.
So for context, for part of my project, at the end of every workshop, we had a choreography piece that all the participants, we would do together. We would teach them, and then for half of the segment, we would do it with our eyes open, and then the other half, we would do it with our eyes closed. And then that was just like one choreography segment, but we did it after the end of both workshops. And for my personal close reading that I did for my capstone project, I close read those choreography segments. And when doing so, it was interesting because I think I reflected on a lot of my health journey when I was younger and had leukemia. So part of it was like resembling and reflecting off of that, you know, like certain movements where I'm like, oh, this is like a form of trust. And then when you're like moving towards someone else, like how are you connecting that with someone else, and how are you building that sense of community? And so a lot of it I would reflect in that. And I just have a long dance background. I've danced my whole life. So I would rely on like terms that either the instructor would use or I was taught growing up, like how's your posture? What does it mean when your posture is straight versus curved? How do those small differences differentiate what you're saying, and what does that story look like based on the way you're standing, sitting, looking, even just standing still is a form of movement. And so what does that mean in the context of this? So I think that's what Dr. Schaff was asking when she says, like, how did I close read movement? That's how I close read it. Yeah.
I have a question for Anya. Anya, your dancing issue is great for chronic diseases. I implement one time, I'm an expert fibromyalgia in Casa Colina, like group therapy, doing the yoga, biofeedback, Pilates, and all these things. And if you can try this on a disease, chronic disease like fibromyalgia or chronic pain syndrome, it will make a huge difference because it has movement, relaxations, biofeedback in one thing. So I think it's gonna be a good thing. I published something like, I have an abstract before about that, but in a group therapy treatment, I think chronic dancing can be added to the group therapy in the chronic diseases. Yeah. I think it would be a good idea. So I wish one day you have a big abstract for chronic disease.
I hope you're going to help me fund that research too. But yeah, absolutely. Cancer can be a form of a chronic disease, not always. Sometimes it takes years, sometimes people relapse. But it totally, to your point, and that's why this was kind of inspired by like other people who have chronic illness and diseases, and just seeing how like dance or like movement have helped inspire this project. So yeah, I hope it doesn't end here. Thank you.
You know, my question was on reflexivity for Anya, and she absolutely answered it before I got to it. I guess I can ask, because you all did a phenomenal job today presenting your work here. How do you have any plans on sharing this work elsewhere or continuing with the work?
Yeah, absolutely. So I still talk with Anna, and she was like, hey, like if I still don't know what I'm doing for my gap year yet, but she was like, if you're in LA and you're still around, I would love to like continue doing this and integrating dance and narrative medicine into one another. So if I'm still here in LA this next year, like I plan to keep hosting workshops with her whenever I can. She's also opening like one in New York as well. So if I'm ever there for any reason in my life, then maybe I would consider helping it started there and just spreading this and growing it as much as I can.
Yeah, I think the work that I did can be very beneficial, like as we've been talking about, like in clinical practice. And because this was like a semester-long project, I only kind of close read just a few texts, but I feel like in close reading a bunch more, and potentially finding more like maybe patient-centered narratives of narrative humility, which is difficult right now because a lot of patients feel as if the clinical like encounter might be a little bit rushed or needs some improvement. So maybe delving into like more physician narratives, some more patient narratives, and pulling out like the major themes and seeing how narrative humility is being exemplified or maybe not shown at all in the clinical encounter, and making kind of like a larger thing, and using that first for myself, like going into like clinical practice in the future, like being able to slow down myself and be engaged with the patient, but also like making it more known to other like physicians or to other medical students, because I think that this is something that everyone can benefit from, and that can be really, really useful with just like small changes within like day-to-day practice.
Got a lesson plan.
Yeah, exactly.
Got it teed up.
Thank you. Yeah, so this is actually IRB approved. So the full intention with this is to hopefully get it published one day, because I'm really passionate about serving immigrant populations and also doing research to fine tune how to like help the providers who work with them, and then also like hopefully one day maybe even doing workshops with patients or with patients and providers all together. So again, the reason why this one just started with providers is literally because to get it through the review board at USC, there are a lot of considerations with working with immigrants, obviously. So we just kind of started with the providers. But yeah, I'm really passionate about this. Like, this is kind of what I want to do for like the rest of my life. So like, I would love to continue to work on how to like help immigrants, especially those who need the most help and who've experienced their own trauma, and to help the providers. So this is like the beginning, and even if there's not any funding, like I hope to continue to work with La Linterna if it goes well, and if with maybe other groups as well. We have a lot of groups here on campus who also work with immigrants. So yeah.
Right. Well, thank you so much to our first group. And now we're going to go on to the other side and hear from our final two presenters.
Hi everyone, my name is Ivan Ramos. So my project was sort of just born out of like coming to understand how contemporary media sort of like deals with HIV/AIDS. Pretty much like the biggest issue that I found was the fact that most representations now just sort of continue to look at HIV/AIDS through the lens of the crisis from the 80s and 90s. So we sort of still don't really understand what it means to like live with HIV/AIDS currently, like within recent years. So I was really interested in seeing what kind of work is still being done sort of like at the individual grassroots level, in terms of seeing like how people represent their own lives with HIV/AIDS. But in sort of looking at the history of the crisis, what I found was interesting, especially looking at things like the ACT UP movement, was the ways in which images and visual art specifically can sort of help folks intervene and use their art to sort of, represent their own lives against those dominant narratives. And so what specific research questions that I had in mind for my project included: how does one negotiate and craft an identity through art when living with HIV? And then how is art in and of itself an act of testimony? And then how can the act of witnessing and affiliation be reached through visual art? When I was looking for my text, I specifically looked at the art organization Visual AIDS, and they had their own oral history project called The Body as an Archive, and they were sort of looking at current artists who are living with HIV and having them in conversation with one another, sort of talking about their own art and the ways in which they represent their lives living with HIV. But specifically, I chose the oral histories of Jorge Bordello and Beto Perez, who are actually Mexican artists living with HIV. And I was really interested in just how their sort of artwork intervenes on that aspect. And I won't really go into the nitty gritty on like both artists, but I was specifically interested in how like across both of them, their art sort of like looks in ways in which they can reconnect their own identities with the like idea of a diagnosis being added onto it, especially because there was sort of a disconnect with the diagnosis before and after. So their art was sort of in ways in which they can sort of, bridge those gaps between their own identities. But what I was specifically interested in, for example, like on this art piece, which is called Maíz Azul or Blue Corn, was in the ways in which that like, how do I say this? So this specific art piece just really meticulously like takes the corn and like takes off the kernels and then replaces them with antiretroviral pills. And that sort of like meticulous practice sort of becomes an embodied form of the art, the ways in which like his body was able to create this piece and then sort of reaffirm the fact that like him having the virus didn't necessarily like change his own like identity like as an artist, rather it sort of informed it, if not sort of made it more impactful, right? But yeah. And then just sort of the I guess concluding arguments, just the ways in which we sort of look at art not as sort of like a passive thing, but sort of in ways in which that we look at art actively as ways in which we can sort of invest ourselves in them. We sort of try to look for a meaning beyond the image, sort of like what is the art trying to tell us, or like what sort of histories are beyond the image. And yeah, so what I was sort of really interested in is the ways in which that art, and the ways in which we like actively engage with it, like sort of remembering, especially in this case, that we sort of have to remember that this art is done by and for people living with HIV. So sort of centering that with that kind of ethical engagement. So yeah.
Hi everybody, my name is Michaela Pelza. My project is entitled Whispers of Resilience, Chronic Illness Captured. And it really lies at the intersection of narrative medicine, visual storytelling, and participatory research, and centers a population that's not only understudied in medicine, but largely misunderstood. When you have chronic illness, it impacts every facet of an individual's life, physiologically, socially, emotionally. Yet a lot of the times, because their symptoms are not visible to the eye, they're largely unrecognized in clinical and social settings. And so individuals are kind of forced to live without this larger recognition. And so my project really asks, what if we centered these patients' voices, not just in what they would say, but in what they would choose to show? So I worked with 6 individuals who self-identified as having an invisible chronic illness to create this digital photo book. And my main study design, as I mentioned, the first one was participant recruitment. So again, I worked with 6 individuals who self-identified, and they were recruited through both like personal and communal networks. And then the second part of it was this image capturing period. I would initially speak with the participants, and I gave them a few weeks to a month to collect images that really represented their daily lived experiences. And then that third step is really the co-authoring and the editing part. So researcher and participant, we would work together. I would speak to the participants after they sent me their images and a short narrative description. I would sort the images kind of thematically, write some captions, send it off to them, make sure that it was a true testament to their lived experiences and it seemed accurate. And then we would go back and forth in that. And then the final step was putting together the final digital photo book. And then also I sent out their final sections to them and a final feedback form so I could get some more kind of insightful feedback. So looking at my digital photo book, I saw like 3 most salient themes. The first one was about layered illness. As I mentioned before, chronic illness impacts every facet of an individual's life, and it's not usually just a singular diagnosis. And so the blurring of the mind, the body, and the diagnosis was really apparent in the images, the captions, and then also speaking with the participants. Something that came across all 6 narratives in some way, either through those images, captions, or talking with participants, was the concept and idea of mental health and how it bled into their experience with chronic illness. Another thing that was also really common across the participants was the development of secondary conditions. Sometimes this would be a reaction to a medication that they were on or treatment, or sometimes it was just a completely new secondary like autoimmune condition. But then again, just kind of like this defying of a linear singular diagnosis. The second theme was this reclamation of narrative agency. Like I said, the goal of my project was to center patient voices. And I think this was really seen in the diversity between the sections. I'll point to it later, but if you look at the project, the photo book is kind of divided into 6 parts for the 6 participants that I was working with. And it starts off kind of standard with like a little bio and a picture, but across the different 6 sections, you can really see the diversity in the images that they chose to take, sometimes in the captioning. Something that I have an image here that I didn't expect when initially speaking with participants is 2 out of 6 of them actually requested to use photos from the past, which wasn't something originally part of my procedure, but in hearing that it would really center and be a better representation of their lived experiences, I was able to incorporate it into the project. And they really reflected in the final reflection that was a better representation and of their kind of narrative. And so the third theme comes from like more reflection and recognition, and that was more seen in speaking with the participants, and then also that final feedback form that some of the participants filled out. So the final book of my digital photo book is this page called Reflections. And so these are quotes either said verbally to me or that were filled out in that form. And some key ideas that came from this was this idea of normalcy and how people had to kind of slow down and reevaluate what's normal for them and how that might not be normal to someone else. And then also this idea of control and kind of taking it back and crafting their own narrative. So there was really some personal reflection and then also kind of mutual recognition in other people's stories. And then again, this is the correct QR code if people want to scan it later. And then like in summary, I'm hoping that this is more than a photo book. It's really a call to reimagine and reevaluate how we treat chronic illness in medicine. And it really begs the question to ask, what if we made space for these fragmented, non-linear, unfinished stories? Thank you.
Wonderful. Thank you, Ivan and Michaela. Questions for Ivan and Michaela?
I was just wondering if you got to see any of the artists' work that didn't, or did they do work that wasn't about illnesses?
They sort of I don't particularly remember deep in their archive, but for the most part, a lot of their work just sort of really centers around their ideas of HIV/AIDS. They do actually do a lot of work. Well, one of them specifically. I've also seen a lot of work just being done around a cultural sort of exploration of their identity, so more focused on their Mexican heritage rather than HIV/AIDS. So yeah, it sort of tackles both worlds. Yeah.
Other questions?
Michaela, I wondered if you could read out those reflections out loud and tell me if they're similar to common themes that you found in work.
Okay. So here are some of the reflections. It helped me grieve and celebrate at the same time. I feel less alone. The process made me feel seen, not by doctors or even friends, but by myself. What I call normal is actually a full-time job. Seeing my section next to others reminded me that I'm not alone, and holding the camera made me feel in control. So yeah, like I said earlier, some of the ideas that came across was this slowing down and reevaluation of your life and normalcy and how that can look really different. Something that was really interesting in speaking to one participant who had lupus since she was 10 years old is that she told me she had to call her mom and ask her, what about my life isn't normal? Because she can't even remember what's so different about her life compared to other people. And then again, that feeling of mutual recognition in other people's stories really showed that not only personal reflection, but also kind of finding community despite the fact that none of the 6 participants had the same diagnosis or story.
Thank you both, and thank you everyone, all the presenters. It's your projects are so different, and yet they're both really invested in the way that visual kind of is a way to tell a story, and it echoes the first 3 that we heard from as well. So I'm wondering if you can step back, and this is maybe going to invite our other presenters in a little bit, but how did your projects evolve or take shape in relation to each other? So as you were helping each other, commenting on each other's work, learning from each other, what are some of the ways that you learned from each other how to kind of craft and think about this work and its relationship to narrative medicine?
I love that question. Who wants to go first?
I think, like you said, all of our projects are really different. So we kind of came into Capstone with kind of a preconceived idea of I want to do something with photography. Anya wanted to do something with dance. But something I saw that was really common is just this idea that even though we're a narrative medicine program, is this idea that sometimes there are limits to what words can say. And so kind of finding ways to kind of combine narrative with other things I thought was really common. Ivan has pictures in his project. Anya did something with dance. So this idea that things sometimes need to go further than words seemed to be a common theme, and we would talk about it a lot.
So this is an interesting question because I applied to this program knowing that I was really passionate about doing something with narrative medicine with workshops, because I've done work with workshops before. But one of the things that I really appreciated was that in thinking about how to really craft a workshop plan, even though of course we're still in the process of it, it was really nice to get everyone's input and also professors and other students in terms of what poems could really help a group of people who spend every day working with people who have very different stories and who are stories that are full of so much strength, but also a lot of trauma and a lot of difficulty. So getting people's opinion on a poem or a set of poems and kind of whittling it down to what could really help people was, I think, a really great kind of collaborative process, just to think about truly like how do we make these interventions or make these projects like really help the communities that we want to work with. So that was like a lovely process because I had so many ideas and I was super passionate. I kind of Dr. Howell is also my other advisor. I came in like kind of like guns blazing in terms of what I wanted to do, and there was like a lot of like, you know, difficulty with IRB, but it was really wonderful also thinking about and slowing down like how do I really choose the best poems and the workshop plans to really, really help these like wonderful providers. So that was really nice. Yeah.
You want to go for it?
Yeah, so like Saba said, like all of us came in thinking that we had like our clear like path of what exactly we wanted to do and that we were going to carry it out like in those exact steps. But in sort of hearing from each other when we would like share our ideas in our like capstone class, at least like for, I could say for myself, like I came in with like kind of like broad concepts of like, okay, I want to be able to like delve into like a physician narrative, but I don't know, you know, what exactly I would want to do or like what path, because it can go down like several different paths. And with people's experience, like close reading their own things and like close reading being such a large component of narrative medicine and us all having a lot of experience in our other narrative medicine classes with doing that, like hearing those ideas from like Ani, Michaela, Saba, Ivan, like telling me that, you know, oh, I did this for my capstone. So maybe if you're taking it down this different direction, you know, you can kind of do the kind of same essence of, you know, here was my like larger general plan of how I close read or how I incorporated the core tenets of narrative humility, or narrative medicine. But in its essence, I think that we all like had these different ideas and very different concepts, but at the same time, they all sort of enmeshed in wanting to like improve patients like or individuals living with any sort of diseases lifestyle and like just well-being and mental health. And I think that all of us had that same sort of core goal in mind of like wanting people to like feel better within the clinical encounter or like just in their life. And because we all had that same like goal in mind, we all were able to sort of like draw out from that. And I think that that was pretty cool.
Also following on that, I think something that as we were all going through the process together that we helped each other learn and realize was how to articulate what we were doing. Not many people know what narrative medicine is unless you've heard it from one of us or someone in the program. So learning how to articulate that, and also to the group of people we worked with, and then now to all of you all, how, like, we know what we did. We know how to talk about it with each other now, but how do we talk about it to other people that aren't familiar with this and make it much more accessible, I think was a very strong commonality that I learned so much from, because I would present and they're like, what is this? What is this? And I'm like, oh my God, you're so right. And so now learning to be able to talk about it to the broader audience and not just people who, and make assumptions that everyone knows what narrative medicine is.
Ditto. No, I mean, the articulation part was particularly poignant.
Thank you. What I'd love now is, first of all, a huge thank you to all of our presenters for your it's just great to see the work come to fruition. Frequently at conferences, as many of you know, there's time spent at the poster to talk and go in more depth. So our students will stay by their posters if you want to ask them questions individually or go into a little bit more detail about their projects. So we have a little time for that. There's food left over, so please help yourselves. And a huge thank you to all of our guests for being here and supporting our students. Thank you.